Okay. Can you see my slides there?
We can, Eavan. Yeah, we can.
Brilliant. Thanks a million. So my name is Eavan Brennan, and I'm a fourth year student midwife at the University of Limerick. And this project is called "I'm Afraid That People Will Not Understand That I Loved My Son: Women's Experiences of Termination of Pregnancy for Fetal Anomaly." So the quote in the title, it's from a paper that I encountered during the research. It's not actually part of the research project in the end, but I chose the quote because I think it encompasses really well the range of emotions and stresses that women and their families experience when they undergo a termination of pregnancy due to fetal anomaly, and it keeps the focus on the woman's experience, which is the central aim of the research. So the phrase fetal or congenital anomaly, you might have also heard congenital abnormality, birth defect, or congenital malformation. And it's defined by the WHO as a structural or functional abnormality occurring during intrauterine life, which may be then diagnosed either prenatally or at birth, or maybe it takes a little while in infant life for it to present. So that means at some point during the development in the womb that the fetus has not developed as expected, and it leads, I suppose, at the most extreme then to the death of the fetus or the baby, and at the least extreme to some form of adaptation being necessary in life, be it learning support or wheelchair use or hearing aids, anything like that, some form of adaptation. And congenital anomalies in the fetus complicate around 3% of pregnancies, and 15% of those anomalies are ultimately fatal. In Ireland, 37.4% of neonatal deaths and 26.4% of stillbirths are attributed to congenital malformation. And really, advances in technology, I suppose, mean that many of these anomalies will now be diagnosed in the first or second trimester of pregnancy, but prenatal treatment is either not possible and it also hasn't progressed at the same pace as our ability to diagnose. So we're presenting women with this massive decision then when we give them this diagnosis. They have this huge decision whether to continue their pregnancy, whether they're able to continue their pregnancy, or whether they go for termination. And so this particular research examines the experiences of women who are diagnosed with a fetal anomaly in pregnancy and decide to terminate following that diagnosis. It aims to understand the emotional landscape that women navigate during this experience, and to clarify their needs and the gaps in care that they identify, and to recommend updates or changes to practice based on the findings of the review. So Grant and Booth in 2009 identified a method which they called a mapping review, and then Bradbury Jones in 2019 updated it and called it a focused mapping review and synthesis. The characteristics of the review are identified as using a targeted journals, which are likely to contain relevant material, and a defined time period. So we're identifying trends, patterns, gaps in the research within this particular time, and within this contemporary field of interest. So this research is a modified focused review in order to be completed within the 9 weeks as was necessary. And it is to examine the research into the experiences of women undergoing termination of pregnancy due to diagnosis of fetal anomaly. So this particular method is useful for investigating whether or not we can see a trend or a pattern in women's experiences, whether their gaps in care are reproduced or not in various legal and geographical situations. So for the review, journals were required that would be likely to contain articles addressing the review question, and the question was expressed in the PO framework in order to clarify the search terms, as you can see there, like pregnant, maternal, abortion, anomaly, feelings, opinions, etc. And in order to identify high quality peer-reviewed journals, the SciImago journal and country rank was used. Headings that applied to the area were used for the search, such as nursing, maternity, midwifery, medicine, genetics, psychology, clinical psychology, medicine, psychiatry, and mental health. The papers were then examined and eliminated if they didn't meet the time frame, which was September 2020 to September 2021, or the inclusion criteria, for example, if they weren't written in English or if they didn't answer the review question. 2 papers, for example, were eliminated on the grounds that they only examined the father's experience. So the modified nature of the review, as I said, restricted the number to 5 journals, and the chosen papers in the end were from Turkey, Iran, Switzerland, Denmark, and the USA. 2 mixed method studies were found, 2 qualitative content analyses, and the final paper was a qualitative interview study. All papers identified that women experience perinatal grief due to the termination of a pregnancy for fetal anomaly. So that means that this experience is identified as the loss of a baby. And the acknowledgement of this grief for women was found to be really important when they were experiencing it. And bereavement support is encouraged and recommended by all of the papers. I also found in background research that the neural pathways during this experience that are activated are similar to those of physical pain. So the women are finding this an incredibly emotional, painful, and difficult experience. The choice to terminate pregnancy also, women feel it alters the societal view of their loss. It alters the way in which they communicate their loss, and they feel that it alters the way the community reacts to the loss. So women express feeling that this event will be judged as a chosen loss and somehow seem less painful when they express it if they choose to communicate that to their community. Also, the delicate process of decision making described by the women and their healthcare providers. It's that women want more support with the process, and they found continuity of care really desirable. Actually, the absence of continuity of care was experienced as loneliness, and it just added another emotion to the trauma that the women are feeling when they're going through this stress. You can kind of imagine how that absence manifests as another burden, like trying to get yourself from your fetal medicine specialist to your genetic counselor to maybe trying to understand what your birth options are with your midwife or your obstetrician, and nobody is telling you where to go or what to do. You just have to figure it all out yourself. And that's really difficult, and women really struggled with that part of the experience. But also healthcare providers have said they find it really difficult to give decisional support to women because they're so wary of influencing how the women make their decision, influencing what the decision ultimately is. So a lot of education and support needed for healthcare providers as well. This review highlights deficiencies in the care of women having this experience, and most notably this absence of structure and leadership in providing care to these women. The fragmented nature of the care that women experience is addressed in both the Danish and American papers, and the latter highlights the role that genetic counsellors have in the multidisciplinary team, which links into women's expressed need for as much information as they can possibly have as a key aspect of their care. Women really want continuity of care. They want a named person who is going to lead them through this experience, and as much evidence-based information as they can possibly have, especially as their decision is often time sensitive with regard to, we'll say, gestational age limits, and they really want to make a decision as quickly as possible. They don't want to live with this knowledge and no decision made. So among the primary recommendations of the research, then are a specific pathway for this type of termination as distinct from any other type of termination or any other type of pregnancy loss. It's a very specific experience, and that would be acknowledged with a particular pathway. The study from Denmark in particular advocates the use of the principles of perinatal palliative care for the construction of this pathway. So perinatal palliative care aims to create a plan in partnership with the woman and her family that honours their parenthood journey with due regard to their emotional, spiritual, familial and social needs. And it would also incorporate a named lead professional in each case and provide robust, tailored aftercare and bereavement support that reflects the needs of each family. Ever since the recent change in the Irish law in 2019, there have been calls for clearer legislation in Ireland to avoid hesitancy with regard to criminalisation of healthcare providers. So the hesitancy has been observed as leading to conservative interpretations of the legal situation, and so women experience deficiencies in their care. Fetal medicine specialists also expressed frustration at their inability to provide full care to the women that they meet in this legal climate, and they also express stress created by perceived judgment from colleagues in particular. So legal restrictions really in Ireland just create a class divide. If a diagnosis is not fatal enough, the question is simply, do you have the means to travel? So my recommendation for further research is to hear the experiences of women living in Ireland who have needed a termination for fetal anomaly since the law changed, and to examine whether or not their needs are met. And where we can continue to improve care. Women are the key knowledge holders in this experience, and legislation and policy that takes their needs and experiences into account is necessary to ensure that we're providing the best possible care to women during this extremely traumatic experience. So the key messages here are really quite simple. This type of termination is a hugely traumatic experience that will affect a woman and her family forever. Service provision has not kept pace with our ability to provide diagnosis to women, and stronger leadership and policy are required to meet women's needs. Healthcare providers also need institutional and collegial support to provide excellent care to these women and their families as they navigate one of the toughest experiences that they will ever have to face. And those are my references.
Thank you, Eavan. I think we'll all agree that was a fantastic and comprehensive presentation also. So I'm going to stop recording for just a moment. I think we have about 1 minute for any questions from